This is the musical interlude part of the program. This is very important. And we have here, we have a musical group. We have chimes for you and Dion Dougal, who I can't see. Where's Dion? She has maracas. And what's going to happen is either with a maracas or a chime, after about 2 minutes, we will something, or maracas right over there. Okay? That is way better than a gong. So that's what we got. Okay? So what we're going to ask you to do is, you see Dion there, and Lowell is somewhere. Where's Lowell? Lowell is there. Lowell and Dion, they're going to give you mics. I'm going to ask you, the reporter, to speak into the mic because we have a recorder of the reporter. I just made that up. Who's Kay Campbell, right there. And if she cannot hear you, she will say, I cannot hear you. And this is going to be recorded. You're actually going to get to see and memorialize your wisdom. And it will lead to other documents, but we're actually going to record your thinking. Okay, so if there aren't any questions, if there are questions, we're going to go table by table by table. This is a form of speed dating. We're going to start at table number 1, and we're going to go, this will shock you, 1 and then 2 and then 3, as opposed to some other numbers. And if we keep it to 2 minutes, we will be done in a reasonable amount of time, and then we get to hear the closing address of Pat Matthews. So table number 1, please answer your 2 questions, and there we go.
We didn't get very far on number 2, but I'm proud of our process on number 1. Some suggestions were to establish a partnership of Northern Virginia, get the progress that's been made by the individual partnerships, get them together. As part of that, a big thing would be to first build trust between the different groups and the organizations. Then we can figure out what works really well in each community, pull together an inventory of those things that are working so that we can share with the other communities. Establish particular goals within that partnership that we can try to realize and work towards. Communicate better between the healthcare providers and the broader resources that are available to them, as well as to all of the different groups in the community. Make suggestions as positive possibilities and not as threats. For instance, in trying to get the schools to work with you on childhood obesity, share the results of the research and the health navigators between the different counties. A big part of it would be advocacy. Certainly we've seen the blue-red discussion here take place. Advocacy is a huge part of it. And again, the building of trust with the faith-based communities, particularly the leaders of those communities. Those communities may disagree on their particular faiths, but they all do agree on the social mission of trying to help their patrons.
Thanks. And I'm going to say sort of the obvious, because it's going to come to table 2, 3, up to 19, or whatever table we are, that if you've heard something already that was put up there, unless you have something a little bit different to say, expound on your new idea rather than elaborating on or saying the exact same thing somebody else said. Table 2, please.
Good morning, and I echo the fact this has just been a wonderful conference. We started with the recognition that there are many wonderful examples, and we've got some of the leading government folks from the jurisdictions, and we had a delegate from the state and nonprofit participation. So the first thing we did talk about was this idea that there are great examples. And to pick up on what Dr. Gloria spoke, we really do need to look beyond any one sector and bring that community together. We need to have courage to bring the community together, to collaborate. And to do that, we have to incentivize. Look at different ways of getting to those examples when the YMCA provides the incentive to exercise, and a homeless man living on the street loses 150 pounds, deals with his diabetes and his drinking. He's still unsheltered, but he's healthier, and we have an opportunity to build on that with collaborations. The other thing that was very, from a scalability standpoint, our Deputy County executive director said, sometimes it feels if you can be paralyzed by trying to take everything to scale. Start small, start with what works, and let's keep that momentum rolling. The second piece, we also talked about advocacy, and I think it's the fact that we saw what worked with Medicaid expansion and the start of it, but it wasn't just one voice. It was, the nonprofit and the faith sector saying it's the right thing to do. A business report saying here's the economic reason to do, and the courage to give legislators to act. So we need focus, facts, and need to really come together as a region if we're going to move some of these changes instead of having 17 different priorities each year.
Table 3.
Hi, I'm Michael Cassidy from the Commonwealth Institute. We had a discussion that hit on some of the points that have already been raised, but a few things that we also talked about was the importance of communication and framing and messaging in this work, and how particularly around creating expectations, and when you can create the right expectations to expect something to happen, it can create a very different dynamic. So everybody will have health insurance, everybody will have access to preventative care or those types of things, then that in and of itself can help create a different dynamic, which becomes much easier to then move forward on an issue. And we talked a lot about the recent debate on Medicaid expansion in Virginia as a way of doing that. We also talked about the importance of appreciating the differences in partnerships, that partnerships are important, but you got to understand that some can be rather informal, all the way up to very formal ones, and that's okay because you're kind of need to meet people where they are, and so not having kind of a one-size-fits-all sort of approach to what partnerships you reach out for in your work. And then we had a good discussion on the role of philanthropy and how to leverage those relationships with foundation, let's say, board members who might have good connections with key voices like the business community, and how we can connect those to this information and these insights in order to move an issue forward, given the political environment of Virginia. That business voice is always so critical, and so thinking creatively about how we can do that, especially around introducing them to these ideas of the social determinants of health, which could be quite new. Business leaders may have been focusing more on workforce issues, and connecting the dots for them to these important health consequences of those things, could be a critical way into getting those folks engaged.
Okay, thank you. Table 4.
Hi, I'm Marlene Blum with the Fairfax County Healthcare Advisory Board and the Partnership for Healthier Fairfax. We talked about some opportunities for collaboration that may be being missed, and that we have that opportunities are there that we should take advantage of. The suggestion came, it's been tried elsewhere in the state and probably elsewhere in the country, that the free clinics in Northern Virginia, the other health centers, whether they're county provided or federally funded, get together and identify the places of employment, the businesses that employ all the folks who are using those services. And if it's feasible, ask them to contribute. And if that isn't feasible, ask them to partner with the various entities and provide some of those community health services that we've all been talking about. And that actually might be a productive partnership. We also talked about the opportunities that electronic medical records provide us, that the opportunities for sharing and collaborating are there but are not necessarily being used, and that there are possibilities for more effective and more efficient healthcare if we collaborate and we do share that information. We talked about physician education and provider education, and how that continues to be important in understanding what the ramifications of all of this and in ensuring that there really are opportunities for collaboration. And then we talked about what we all could do. We pretty much agreed that advocacy was probably the most important thing, that we've been doing it and we're going to continue doing it.
Lots of ideas. Table 5.
Our table focused on some existing collaborations that would be important to see if they could be grown region-wide, and one of them that was referenced was oral health care service delivery across the region, that we have some partnerships on improving access and capacity. So we were going to offer that as an idea. We talked about the importance of accessing our regional political leadership, and that one of the places to do that might be the Northern Virginia Regional Commission, that we need to engage our local legislative bodies on issues of importance, and that we really talked a lot about non-health related collaborations, that health is a component along the lines of what Dr. Wolf was talking about all things health strategies. And we started talking about specific populations like the domestic violence victims, and that the importance of behavioral health being offered and available to that very needy folks who have suffered trauma, and how can we build engaging awareness, education for both the people who are victims of it and also preventive strategies. So a lot of communication ideas started coming out about that. And lastly, I think the other strategy action that we talked about was, again, reaching out to non-traditional health partners like law enforcement, that the importance of education of the health safety net system and the awareness of resources that are available to people they come in contact was an important idea that came out of our group.
Thanks. Table 6. Please make sure you speak up because you're the furthest from Kay.
Hi, Grace Keenan, CEO from Nova Medical Group. Well, this group talked about the collaborative entities that currently exist, and trying to get those, improve the collaboration, I guess I should say, between the organizations that currently exist, such as the Prince William Health Partnership, and perhaps there be ultimately one entity that kind of links all these different do-good organizations together, and that would probably help prevent some of the silo issues that are going on. That we would look at communities that have good outcomes and then try to learn from those communities what could be done differently in those communities that have less optimum outcomes, and that currently the census data is being used by some of the community clinics for this purpose, and that we could expand upon it that way. We also talked about incentivizing people to make the lifestyle changes that they need to make, so that historically we've seen a lot of what we call G1 efforts in corporate wellness. Arlington, for example, offers a stipend if you bike to work, so there's incentives such as that. But now going to corporations and helping them identify their top risk issues that are most expensive, and then helping them to implement changes in people's behavior, not just having the worried well show up for a walkathon or whatever, but to actually reward people for participating in getting health risk assessments done, and then fixing or working on fixing the issues to their particular health.
Just one more comment, please.
Yep, and we talked about access to health, access to food, and the cost of what's rewarded for food stamps, $1.54, and trying to help people identify how they could cook a meal and be taught on that. Okay. If I could just make one more comment, better communication with different departments, like Department of Transportation, doctors, housing, the environment, and also electronic medical records, with improving the portability of the healthcare record. Thanks.
Thanks. Table 7.
Much of what has already been said, particularly around messaging, regional approaches, and utilizing the people that we already have and the coalitions that we already have as a start, have been said. So I'm going to focus on specific sectors that we spoke about. One was looking at employers, kind of at an employer level, and how do we educate them, recognize the work that they're doing, and help incentivize that kind of thing. The importance of schools, both recognizing the importance of schools as environments for healthy living, and recognizing the importance of kids as change agents and the role that kids have played, for example, in getting people to buckle up or to stop smoking. The philanthropy sector, and you mentioned earlier the importance of philanthropy, and I think that there's going to need to be a shift in how funders fund things, because for them to take into account social determinants of health, there's going to need to be a more long-term investment in programs. Most grants tend to be for 1, 2, 3 years and have very importantly and correctly focus on outcomes to participants. But when we're talking about a lot of the things that we're talking about here, it's a longer term prospect and the impacts aren't as directly noted, particularly over a short term. So we're going to have to really figure out how to bridge that gap.
One more comment, please.
Okay. Health professionals at the provider level, at the individual provider level, how do we get them talking to each other and identifying the ways that they can improve their services?
Thanks. Table number 8.
Hi, good morning. I'm Angela McConnell with Q Integrative Healthcare. I also work on initiatives with the Prince William Chamber of Commerce and Live Well Prince William, Manassas City, Manassas Park. A lot of the ideas have already been mentioned, so I'm just going to go straight to the idea of establishing a group of individuals that could work together to provide a health impact assessment, and this would be to determine, what's important in our region, and it also would give us some outcomes that we could bring to our policymakers, that we could bring to our stakeholders, our philanthropic providers in the community. So that was really important, and one of the ways we talked about how to do that and how to break down the silos was to have someone, let's say, within the Virginia Department of Health that would go around within their own individual departments, like planning and zoning, and kind of look through a healthcare lens as all of these ideas and concepts and plans are being developed and determine what kind of health impact, should we be looking at. And then take those individuals and go across the community and find the leaderships from like the American Medical Association, their point of contact here within this region, and talk with all of these different leaders, providers, community agencies, nonprofits, and come together and develop this health impact assessment to be able to use for the information and for the outcomes that I discussed previously.
Terrific. Number 9.
Thanks. Phyllis Kay, the Regional Primary Care Coalition. We talked about much of what was already discussed. The new points are, we identified some people who are not at the table very often, and those are some of the payers, the health insurance companies, and groups such as that. We also talked in the context of schools about not forgetting the faith-based schools and not forgetting the teachers within the schools. So it's not just the systems, it's the teachers themselves. We talked about looking within our own organizations, much as you did with the health department, to see where cross-sector collaboration could be encouraged and put forward, be it a university, be it an independent city, county, or whatever that from a health perspective is part of a larger county system, and identified some folks that we put on the paper.
So we're halfway done, and so if this were television, there'd be an ad at this point at intermission. So I have an ad. If you haven't seen today's Washington Post, this is not the Washington Post, but it's a piece of paper off a computer. Headline, binge drinking depression among health issues in Northern Virginia, study finds. And it mentions this summit and the fact that we are gathering here to try to come up with solutions. And the story says that. So pick up your Post because you're more famous than you know you are. And that's the end of this ad. We'll move to table number 10.
Good morning, Sharon Arndt, Partnership for a Healthier Fairfax. We discussed many of the issues that have already been addressed, but one thing we really focused on are the silos, and the silos between our communities, not just within our communities across our sectors in the community, but those between Fairfax and Alexandria and Arlington and Prince William and perhaps Loudoun. We just don't know. We're not working together well enough. The other community that has not been addressed at this time is our federal military community, how we're not engaging them in what's going on locally or engaging them enough. Some of the concerns at our table thought that within the silos there needs to be an easier access to the resources so that those that wish to broaden their approach can do so without expending too much time or energy. And then the final point I'd like to say is that we emphasize that there is a concern with not enough data out there and sharing that data appropriately between each other.
Thanks. Table 11.
Cindy Daly, Northern Virginia Family Service. No surprise, we spend a lot of time talking about education, health education, and some of the outreach. One of the examples, of course, is going to be the Navigator, and we have somebody here from DC who's working on their Navigator program, so very exciting. So the collaboration that we're looking at across the region to be able to come up with some across the region messaging, across the region work on how do we impact the immigrant communities and what are some of the messages we have to get to them. That are going to have to be contextual about where they've come from and what they understand about health or not, and how to use it. So there's just an access piece, but then there's also how do they use and make use of and understand the benefits. The other group that we talked about was a little bit about the media, that as the airwaves start going on about access to the health exchanges, we are going to have a difference here in this area because of the Maryland, DC, Virginia boundary. And so how do we help our constituents understand the differences about what's happening in these jurisdictions?
Thanks. Number 12.
Hi, I'm Lori Cooper from Inova Community Health, and we did talk about a lot of things that have been mentioned, among which we could add the following. We talked about the chairs of the partnerships processes in the various Northern Virginia jurisdictions coming together on some kind of regular basis to share resources and to plan together. And perhaps out of that, I mean, it is complicated how that would be organized, but one thing we came up with is the idea of a shared communication committee that would act on behalf of all of the partnerships so that if there was major activity, in terms of, they act as strategic catalysts, they plan, they have programs, and our thinking was that they could, this committee could then publicize what was going on in each one with an eye toward how it was being coordinated with the others, whether there was planning going on and related programs in another jurisdiction. We also talked about the chairs considering their potential impact, representing the MAP processes to impact state legislatures, or the state legislature, just one in Virginia, and using the hospital community health needs assessments that are required at this point by the IRS to inform future assessments. So we're 3 years out from the Affordable Care Act's next round of community hospital needs assessments, and we talked about the MAP processes sharing data with the hospitals and with each other so that we can, if not combine this all into one assessment, at least figure out how to streamline. Maybe one section can be done by different organizations.
One more comment, please.
Okay. Our last comment was to speak where you haven't been heard before, to leverage existing regional organizations. For example, the CSB is organized at the local level, but also regionally, and to try to tie that in as well with the MAP process.
Thanks. The other side of the room, table 13.
Hello, I'm Carol Jameson from HealthWorks for Northern Virginia. Much of what we discussed has been already covered. I'll just expand a little upon what Table 2 said. We identified two models right now that have embarked and are working hard. One is targeting a neighborhood in Fairfax County where 25% of the residents are living in poverty, and there are 14 nonprofits and county services that have come together in a co-location model with a health-centric focus, with a community health center at the center of that, to really look at how we can change those social determinants at that neighborhood level and then take that to a broader community. In Alexandria, through their partnership, they've identified a common goal, as Dr. Gloria mentioned, and that has then led to really the assurance that a multi-sector group of folks are working very collaboratively on that. Among the other, I guess, lessons that we came up with or recommendations, just to make sure that we all seek voices that are very diverse. We think of cultural diversity, but we mean diversity in the employment sector and et cetera has been mentioned. Be willing to pose the hard questions. Have an atmosphere that sort of says from the start, we're going to pose these questions, we're going to trust each other. Look beyond our own comfort zone. Change how we approach the goal. If it's not working, be willing to talk about that. Really have a constant kind of atmosphere of almost self-evaluation as we move forward. And then within our own organization, several of our members talked about how thinking in this way had led them to really evaluate how they deliver services or the services they deliver and how they can reach across the community to maybe start slowly and then build a much broader collaboration. And so it doesn't always start, as I think someone said, we think we have to start big. If we just start small, we can get there in steps.
Thank you. Table 14 looks like a mighty table.
Well, one nice thing about being near the end is most of the stuff has been said. If you don't like to speak a lot, this is great. We did mention a lot of the items that have already been noted, but we talked about the silo on the very individual level between the consumer and the medical care provider, and how to talk to each other, and how do you break that down and educate people so that when a doctor, doesn't treat you if you don't know the lingo, like you're an idiot. Not that they do, but it could be the perception. So we talked about those narrow silos to bridge that gap. And also, we talked about where do you go to engage people on a greater level when you do healthcare education? Is it the mall if you do your blood pressure workshops or whatever? But what do you do when they get that information? Where do you send them? And you have to build those partnerships first before you just give them the information and give them no place to go.
Table 15, table of 3.
I'm Mary Mosley. I'm from Northern Virginia Community College, the medical education campus. Our group took a little different spin because we want to walk the talk. We're into evidence-based practice, healthcare outcomes, which is all based on data. So therefore, when you're working in interfaith groups who do excellent jobs at health promotion and prevention, they have to be accompanied with data. So that's where you put in the education system, such as Northern Virginia Community College and our medical education campus. We actually have a dentist who gives dental care, not just teeth extractions either, but on a fee-for-scale basis. That's a community college level. We have students that take statistics. Get them in the literacy programs out there that teach students in underserved areas of medical services and have them help drive data as well as teach the students. So we believe that all politics are local. So therefore, there's not one district here. If there is, I'd like to know, besides that Falls Church one, I was quite impressed, that doesn't have a medically underserved area or a health profession shortage area. That talks, that has money in it, because that's where you want to get federal funding as well as state funding, and you want your representative to help promote your ideas, because it's great to love, but if you don't have the data to show it, then you're not going to get anywhere.
Thanks. Number 16.
Good morning. I'm Katie Brewer with Fairfax County. We're actually table 16 and 17, so just in case there's any confusion. We had a table of policy wonks, so we engaged in a pretty in-depth discussion around the political realities of health reform and health care, as well as the provider side and the service delivery side. And what we really talked about that's different from what we've seen already is this idea of telling your story in a way that the other side was going to listen to. So it is about including cost, it is about talking about jobs and employment, it is about framing the narrative in a way that's going to engage the people that aren't going to listen to you if you're not talking the language that they speak. So I think sometimes that's difficult to do in healthcare because we want to do the right thing, we want to make people's lives better, but we have to make sure we mentally and consciously break down that own silo of being able to talk about things in different ways that's going to get people on the same page with us.
Thank you. Jumping to 18.
Hi, I'm Danny DiVittorio with United Way. Really, we're table 18. We've pretty much said everything. I promised my table I wouldn't just say ditto. So basically what we had talked about with the collaboration side was that really communication is key. The nonprofit to nonprofit, we need to improve that. But really cross-sector to make sure that the nonprofits are talking to the government's talking to for-profit, we're all together. So the one thing that we really discussed, because we do have someone from the Council of Governments here, was using platforms that were already in place to improve that communication. So the Region Forward Committee for 2050, we really thought we could use that as a platform to start the discussion about how the different areas, the different subcommittees really do affect public health and then what they could do. And then further from that, we really started talking about just raising awareness and education on different services, educating service providers about nonprofit services and things of that nature. Pretty much everything else that was already said.
But it turns out the table 19 has a lot to say. So.
Well, sir, being number 19 puts us at a distinct disadvantage because there's quite a lot of good ideas already out there. My name is Frank Principe. I'm the executive director at the Greater Prince William Community Health Center. We are a federally qualified health center located in Woodbridge, and over the last 5 years have cared for about 25,000 patients at 100,000 doctor and dental visits. We had a mighty table. We have representatives from the nonprofit sector, the for-profit sector, local government, and academia. And we came up with 2 opportunities and potential solutions for your consideration. The first is, we all know, we all see on a regular basis a discrete, very urgent need for referrals to specialists, be it psychiatry or endodontists or orthopedics. While we can, as a safety net, provide the primary care and the dental care, we'll need at some point to refer our patients on to specialists. And given that need in the uninsured community, at Greater Prince William, we are pursuing a little-known tax credit program in the state of Virginia. You can write this one down. It's the Neighborhood Assistance Program, or NAP. It'll take you 3 different state agencies to get more information and to apply. But once you've applied as a nonprofit providing human services to low-income families, you will be put on an authorized list to be a recipient of either cash or in-kind contributions, including the hours donated to you by a specialist, like a psychiatrist. The way the tax credit works, if you're approved and the recipient of one, a specialist practice who pays sales tax would, I believe, get a 60% tax credit on that sales tax, pay the state the 40% they owe, and give us the 60% as a nonprofit. So that's a very interesting program. We have applied recently. I'm told there were about 300 applications that have been received. You know, there's a window of application each year. And we are holding our breath and keeping our fingers crossed that in fact will be a potential solution until the insurance marketplace and Medicaid expansion occurs in Virginia. The other opportunity, very quickly, we all realize patient education and health literacy is a common theme, a common need or demand in our community. And while we all have brochures and we all have websites, the one thing that differentiates our patient population than most is they don't have landline telephones. What do they got? They got cell phones. They got smartphones. So we'd like to ask Pat and Tricia and everybody involved to create an app. 2-part app that is patient education, be it diabetes, heart disease, whatever it is, and a link on that app to the closest safety net provider that can provide services based on a GPS system. It's kind of an interesting idea. But thanks for the opportunity.
Terrific. No shortage of ideas. That was fabulous, actually, just got to say, from being here. So this was, I said, and you heard from Pat earlier, this is the beginning of the conversation. We're by no means done. This is day one. And I'm going to turn it back to Pat to tell us where we go from here.